All right, the number is holding steady, so you can go ahead and get started. Do you mind going to the next slide, please? All right, welcome everyone to the group chat. We're excited you're joining us here today. Just a couple of housekeeping items. We will do a Q&A, so you should see a Q&A box at the bottom of your screen. Feel free to submit questions throughout the presentation. I'll be reviewing them and compiling them, and at the end, Dr. Collifer and Dr. Patnam will answer them. The presentation is being recorded today. However, no participants will be identified, only the speakers. And as a reminder, the information shared during this presentation is not medical advice, and we will provide additional resources if you have concerns and would like to speak to a physician. And with us today, we have Dr. Rachel Collifer, who's a minimally invasive gynecologic surgeon at AHN, and Dr. Radhika Patnam, who's a urogynecologist at AHN. They both practice within AHN's Western PA OB-GYN multi-specialty group, and today they're here to share their expertise about endometriosis and pelvic pain. So without further ado, I will pass it off to them.
All right, I think I'm going to be going first. So like Bree said, I'm Dr. Radhika Putnam. I'm a urogynecologist with an interest in pelvic pain. I thought what we could do today is just kind of go over what pelvic pain is. It's a big topic that has a lot of components to it. And a lot of times it can get pretty confusing when discussing it with patients and also kind of looking at information that's available on the internet or other places. The big thing to understand about pelvic pain when we're talking about it is that it's not usually from one system. So there's a lot of different things involved. Next slide. And so pelvic pain is really just very loosely defined as pain that's below the umbilicus. So anywhere below our belly button is going to be somewhere that we're going to talk about something being pelvic pain. Chronic pelvic pain is when this pain lasts for 6 months or more. And really the question becomes, is it debilitating? Is it something that's kind of taken over your life? Is really when we start to really define it as that chronic pelvic pain. And only about a third of women with chronic pelvic pain actually seek care. So it's definitely something where a lot of women are living with this and not really getting the care that they deserve and need. And so it's important to kind of talk to your gynecologist or your provider at the beginning to kind of ask the questions and make sure we get you to the right place. And finally, it can be really difficult to diagnose. And the thing to understand here is that the source of that pelvic pain can be coming from a lot of different places. Okay, so causes of pelvic pain. The first one can be gastrointestinal, and we'll go over into that in a little bit more detail. Next. You can have neurologic symptoms, and we can go into a couple different sources for those neurologic pains. You can have musculoskeletal issues. And this is actually a really big cause that affects a lot of different women in a lot of different ways, and is a really important thing for us to consider. And then finally, urinary. As a urogynecologist, I'm going to be seeing a lot of those patients. You can see here the thing I haven't actually mentioned is gynecologic, which seems kind of strange for pelvic pain, but the reason for that is because that Dr. Collifer specializes in a lot of that. B, I do part of it, but also it really wants to reinforce that this can be starting from a lot of different places. And part of what we do as doctors is really try to help narrow down where the source is so that we can help that to help your pain better. Next slide. I'm going to go really briefly into the gastrointestinal to start with. There are a lot of different conditions that can be really commonly associated with pelvic pain, irritable bowel syndrome. So sort of that bloated, constipation, diarrhea, back and forth, often exacerbated by stress or food. Inflammatory bowel disease, which is a more concerning thing of sort of having ulcerative colitis or Crohn's disease. Often that's going to be diagnosed earlier in life, but sometimes can be later and definitely needs a gastroenterologist to manage. Diverticular colitis, really common for patients where they don't really know the source, but just sort of having abdominal pain, bloating, discomfort with eating a lot of the time. Celiac disease, and then just chronic constipation can all lead to really pain that's below that umbilicus, like we said. So pelvic pain that we're not sure of the source of. I'm not going to go into as much detail with these, mainly because these are all things you really need to see a gastroenterologist for. And that one of the things that I can do as a pelvic pain doctor is get you to that gastroenterologist to kind of get you to that next step. But just to know that this is part of that sort of group of things that can lead to pelvic pain. Next slide. The next thing we're going to talk about is neurologic pelvic pain. They can be caused by a lot of different things and a lot of different changes that go on in women's lives at various points. It can be caused in terms of like nerve injury and entrapment. This can happen for a lot of different reasons. I think a lot of women will come to see us with some pain after delivery. And this can be from where the baby's head's positioned, where their legs were during delivery. It can be during the repairs when people have tears during delivery. Anytime anyone has a surgery, there's a lot of nerves that can be damaged or even just injured. And some of that can take some time for recovery. With nerve injury, the big thing to try to understand is which nerve is the source of the pain. There's a lot of different ways for us to do that, but most of it's just you telling us what kind of pain you're having and where you're having it, and us trying to localize it. The thing that stinks with a lot of this is that there isn't really great, perfect treatments for it. A lot of it is just a time game. So just waiting to see if that nerve will heal, giving it the time and the space in order to heal, and sometimes doing some medications to help with neuropathy. The other thing I want to really briefly bring up here, because it's a pretty complicated idea, is the idea of centralized pain. And so, what I mean by that is when we think about how our body works, we have a bunch of different sensors everywhere that tell us if things are hot or cold, if there's pressure, if there's pleasure, if there's pain. For one reason or another, especially if somebody already has pain in an area, our body can start to take all signals, so just simple pressure, and turn it into a pain signal. And that can be a really, really hard thing to treat. We often tell patients that this is a centralized problem, meaning it's more brain than it is that localized area where the pain started from. And so, what does that mean? It just means that we have to look at how we're going to treat those patients a little bit differently. It can't just be looking at, the pelvis and saying, how are we going to fix this? But also, how are we going to work with how the brain is interpreting that information and dealing with that pain? And those are often medications. Sometimes some physical therapy can help, even though that does be ends up being a little more localized. And sometimes it can be figuring out some of the other things that can exacerbate central pain. Things like stress really play a role in pelvic pain and end up being a massive problem. So it's something that we really need to make sure that we're working with. Next slide. And so we're coming on to sort of musculoskeletal pain now. This is probably the most common thing that I see, and something that Dr. Cullifer and I will share a lot of patients with. And the reason for that is, musculoskeletal pain and myofascial pelvic pain syndromes can really start for a variety of reasons. They're defined as dysfunction, spasticity, or hypersensitivity of the pelvic floor muscles. And as you can see here, there's a heck of a lot of pelvic floor muscles that we have. And in particular for women, these muscles have to be strong enough. They're going to hold in urine, they're going to hold in stool, they're going to keep our pelvic floor in place and support our body for active sort of everyday movement, including walking. But in the same breath, they're supposed to be relaxed enough to let out urine, to let out stool, to be able to deliver babies, and to allow for intercourse. So there's a lot of movement that has to occur in these muscles. These are muscles that can be damaged easily during deliveries, is a common thing that everyone kind of thinks of. But there's a lot of other places it can happen, falls, injuries, sometimes even just not exercising properly. So we are all told 1,000 times during every yoga class to breathe in and breathe out appropriately. And I know I don't listen all the time. But if you kind of become aware of why they're telling you that kind of stuff, you'll see that you're squeezing muscles inappropriately sometimes just holding tension in different places. And again, stress can play a big role in this. We all hold tension in different ways. And for some women, they actually are holding their tension in that pelvic floor, and that can cause a significant amount of pain and discomfort as well. This is typically assessed during any GYN exam. Often what I'm just going to do is put a finger in the vagina and just feel those muscles. See if you're having any tenderness when I'm pressing on them, see how tight they feel, and ask if it recreates any other symptoms. One of the most interesting things about the pelvic floor muscles is that often we will have pain that we describe as bladder pain, ovarian pain, uterine pain, lower abdominal pain that's actually recreated by pushing on those muscles. And it seems kind of counterintuitive, but it's just because of how our brain interprets information again. So it's taking that information of that tension and that pain and kind of telling us, okay, well, maybe it's this, and this is what I'm feeling. And then your brain kind of runs with that. And so it's really important to have a really thorough pelvic floor exam, especially when you're having a lot of pelvic pain. And a lot of times this can be secondary symptom to another issue. So when we are in pain, whether it be from, we're talking about the IBS and the GI pain or the neurologic pain from a nerve pinching, we start to tense. It's just like our shoulders start to tense if we're in pain, if we've got a headache. our pelvic floor can tense, and that can actually start to lead to sort of a secondary pain on top of that first primary pain. And we have to kind of parse through how to manage all of those to help someone really get better. Next slide. In terms of urinary pain, there's a lot of different kind of things that people think of, but the most common one is going to be interstitial cystitis, which is more commonly known now as bladder pain syndrome. It's a chronic symptoms of a urinary tract infection, so pain, urgency, frequency. You're going to have urine cultures that are often negative, so you're going in, you're like, I have a UTI, I've got all the symptoms, but your urine is just coming back and there's nothing growing in it. We describe this as a diagnosis of exclusion, meaning there's no clear thing that tells us you definitively have this. It's more like you don't have X, Y, and Z. And so we kind of decide at that point it's most likely going to be bladder pain syndrome. This can be associated with a lot of other pain syndromes. So fibromyalgia, sort of just general fatigue can be associated with this. Irritable bowel syndrome is definitely connected along with endometriosis. And so it's definitely a condition that takes some time and some effort to get improvement with. It's not a one medication is always the solution for everyone. One method is always the solution. And you also want to remember it can be associated again with that pelvic floor dysfunction. So it can be one is making the other worse, along with that IBS that we were kind of talking about. So all of these can be really interconnected. There's other urinary things that can go on, recurrent urinary tract infections. Sometimes certain dietary things can really set off our bladder. A lot of times they can be things we were always able to drink, like Diet Coke. Pretty much everyone who's worked with me has heard my anti-Diet Coke spiel, which I know everyone likes to hear. But in general, sodas, bubbles, anything that's acidic is really going to be irritative for the bladder. And for some women, just as time goes on, that bladder becomes more irritative. Next slide. And then finally, we're getting to the gynecologic here. And there are a lot of sources for pain that are gynecologic. This image here is just something I pulled from a report or an article that came online, but I thought it was great because it was kind of listing everything I could possibly think of. You know, when you're younger, you have the menstrual cramps and the ovulation pains that kind of are cyclic and are happening. We have the endometriosis, which Dr. Cullifer is going to go into in more detail. Fibroids can cause pain for patients. I also do pelvic organ prolapse surgery and management of patients with pelvic organ prolapse. And while it typically doesn't cause pain, it definitely can cause a lot of discomfort for women and sort of the pressure, bulge sensation, feeling they're sitting on like a golf ball kind of thing that can get uncomfortable. And actually women can start to tighten their pelvic floor muscles because of it, leading to more pain and discomfort. The other thing that you always want to consider with any of this is a common condition called vulvodynia, which I'll get into in a little more detail now. Next slide. And so vulvodynia is a condition in the vulva without an identifiable cause. I love this particular document here. It's a Nature Review disease primer. It's meant for patients to be able to look at and sort of get a generalized sense of what's kind of going on in the world. So I'm not going to go over every single detail on it. I just thought it was pretty helpful to take a peek at. Basically, vulvodynia is the idea that your vulva hurts and you don't have an explanation for it. There's no infection, there's no tears, there's no skin changes, it just hurts. And what is the source of that? That kind of fits back into that neuropathic pain a lot of times, so can be that. It can be dermatologic sometimes and we're missing it. There are conditions that can cause changes in the skin texture that are autoimmune that we need to look for. And once you kind of knock all of those out, you kind of come to the vulvodynia. Vulvodynia is often, like I said, a neurologic condition, and there's a lot of different ways we can look at to manage it. The centralized management, the management with creams and things like that to help with pain. Diagnosis for it can be really hard. It's just a matter of kind of feeling and touching and asking patients, does this hurt? Does this not hurt? Trying to pinpoint where the source of the pain is. It can be provoked, meaning it only occurs if something touches that area and irritates it, or it can be unprovoked, meaning you just sort of have this constant burning that's going on, and that becomes a major factor in your life. You're changing your clothes, you're changing your activities that you want to do, you're trying to avoid certain things to avoid that discomfort. So it's a condition that can have a lot of issues associated with it, and it's one that we just don't have enough information about, but it's definitely something that's worthwhile to discuss with your physician if you are having symptoms. Next slide. And then I'm going to pass it over to Dr. Culliford to talk about endometriosis.
Thank you, Dr. Patton. So I'm Rachel Culliford, and I'm one of two sort of endometriosis pelvic pain physicians in our group here. And I was just going to discuss the most common cause of pelvic pain and kind of some ways to diagnose it and treatment options. So it's very common. It occurs in 6 to 10% of women of reproductive age. In someone who has chronic pelvic pain, it ends up being the reason in almost 70 to 80% of women. And then family history also plays a role. If you have a first-degree relative with endometriosis, and you have a 7 to 10-fold higher risk of developing endometriosis. I get asked a lot if it's genetic, and there's no necessary endometriosis gene, but it seems to be a bunch of different genes kind of interplaying, and there does seem to be a family link, a family risk, but there's not exactly like a gene we can test for, like specifically for endometriosis. How it occurs is very complex, and there's still a lot of debate about why it happens. There are a few different theories. The most common that people kind of come into my office knowing or thinking about is retrograde menstruation. And that means that whenever someone has a menstrual cycle and is currently bleeding, instead of all that blood coming down through the cervix and out the vagina, it's going back up through the tubes into the abdomen and kind of creating these implants or seeding the abdomen. This theory works for most instances. However, we do know that many women have some element of retrograde menstruation. They've looked at women on their periods with an MRI and seen that many women have blood coming back into the abdomen, but not all women develop these implants and develop this like inflammatory reaction. So there's still a link that we're kind of missing that I'll go into a few theories in a minute. There's also a theory of spread through the lymph system or the blood vessels. That explains how it can get into far-reaching areas, which is extremely rare. But I mean, you can have cases in like the lungs, or there have been some cases of males having endometriosis. And as you can understand, the retrograde menstruation theory doesn't really explain that. So people have kind of looked at other theories, and one of them is, again, spreading through like the lymphatic system or the blood system, and maybe that's why that happens. And then there's another one, it's called chalamic metaplasia, and it basically says that at development, whenever you are just like a little embryo and you're a couple layers thick, that the cells jump to the wrong layer, and essentially you have these female reproductive cells implanting and growing in the wrong layers, which is like the inside of your abdomen or your peritoneum. Regardless of which theory you use, we do think that there is some participation of the immune system in creating such an inflammatory response. So however the implants get there, this slide is using the retrograde menstruation theory. It does show that once these implants kind of attach, that they basically are able to kind of recruit their own blood vessels. That's angiogenesis. They can activate the immune system, which kind of attacks your own tissue. They can kind of invade the cell layers. And then there's even some evidence that they can even recruit and grow nerves. So that makes this extremely painful. And it doesn't really respond to our normal immune responses. In short, you know, if blood comes into our pelvis, our body should kind of resorb it. Our immune cells should kind of like chomp it up and get rid of it, and that should be it. But in these cases, it's creating a local inflammatory reaction, and it's really kind of attacking the tissue surrounding it, and it's not really getting rid of it, but just creating sort of a lesion or a point that can be painful. And we don't quite understand why some women do that and other women don't. So how do you know you have it? Mostly off of clinical, you can make what's called a clinical diagnosis, like based off of signs and symptoms your patient tells you. So typical symptoms are cyclic pelvic pain. So if you have pelvic pain every day, and it doesn't vary in intensity, it's probably less likely endometriosis. Whereas if you have pelvic pain that really starts a couple of days before your menses, through your menses, and a couple of days after, that's really kind of your typical pattern for endometriosis, when you get that worsening pain with menses. It typically starts when you're very young. So usually these are people who have like, oh, I had to miss high school for pain. I couldn't go to like my friend's party for pain. Like when you're young and you really want to do things, having this sort of extreme pain that's preventing you from doing the activities you want to do, that's kind of a red flag for endometriosis. That would be an abnormal amount of sort of just typical cramps or pelvic pain with menses. Pain with intercourse, a backache during menses. So having that pain even start in the front, kind of radiating back to the back, that's kind of classic for endometriosis. And then pain with bowel movements or urination, specifically worse with menses. In the office, a doctor can do a physical exam, and we can try to feel the uterus. And some things we're looking for are, is the uterus stuck? Do we feel like we feel scar tissue? Are there little nodules back behind the uterus? Those are kind of all, again, red flags for endometriosis, and kind of more pieces to the puzzle as we try to figure out what's going on. And then we can get imaging, which can show endometriosis usually on an ovary in the form of an ovarian cyst, which this specific type of ovarian cyst is an endometrioma. So in short, endometriosis is whenever a tissue similar to the lining of the uterus grows anywhere besides the uterus. One of the common places it can grow is on the ovary. And if that occurs, it can form what's called an endometrioma, which is a specific type of cyst. So it's normal for our ovaries to make cysts every month when we ovulate. Those are usually described as follicular or simple or functional cysts. But if this type of cyst is seen on ultrasound, then we are more suspicious for endometriosis. However, there are no screening tests for endometriosis. So unless you're having a lot of pain, unless you're having some of these symptoms, and then we move to like an ultrasound, if you're not having these symptoms, there's no need to go get an ultrasound just to look for it. With that being said, ultrasound can't really see those really fine, they almost look like freckles. And we'll look at some pictures in a second, but they almost look like little freckles in the pelvis. So like on ultrasound, unless there is an ovarian cyst made by endometriosis, it's very difficult to see it on imaging. So if we see an endometrioma, we can say we're pretty sure there's endometriosis. If we don't see anything, if it's a perfectly normal ultrasound though, it doesn't rule it out. So I have a lot of patients who get discouraged when they have a lot of pain. They get imaging, it doesn't show anything, and they feel like their pain isn't validated. So I just like to really clarify that a negative ultrasound or a normal ultrasound doesn't mean you don't have it, but there are some things we're looking for when we do the imaging to kind of give us more clues. So I kind of moved into diagnosis, but in short, we talked about like the symptoms people will have, the exam findings they can have, the imaging we can get, and kind of put pieces together. But the only way to 100% tell if someone has it or not is to look surgically, and that's called a diagnostic laparoscopy. And during that time, we usually take specimens, things that we think look like endometriosis, and send them to pathology, and they can tell us if indeed those abnormal glands are where they shouldn't be or not. AKA, do you have endometriosis? However, because surgery, has risk to it, and a lot of the first line medications for endometriosis treatment, such as non-steroidal anti-inflammatory drugs like Motrin and birth control pills, since those are usually so benign and surgery has some risks, there is a lot of safety with that first line treatment. So we typically can treat for presumed endometriosis based off of what the patient's telling us, what we find on exam. And that if that fails, we typically move to surgery. So that's, kind of our pathway. Is sometimes people get frustrated that they're being treated for endometriosis with medications without 100% knowing if they have it or not. And again, the reasoning for that is surgery is not benign. While it is really safe nowadays, and it's typically done laparoscopically through little incisions, it's still surgery. It still carries risk. So we usually try one or two things prior to moving to surgery. So I'm going to go through some surgical pictures. If you're squeamish or this isn't your thing, you can kind of shut down your computer or turn away for a second. But I think a lot of people want to understand kind of what it looks like in there, or what exactly are we looking for. So typically endometriosis are these kind of blue-black lesions in the pelvis. And again, this whole thing is just like, this isn't really a true organ. This is just what we call like the peritoneum. So this is just kind of like covering like a cellophane that is inside our abdomens, lets things slip and slide. And these implants kind of bury themselves in what's called the peritoneum. So we're able to kind of pick up these implants and cut like a circle around them and remove that without oftentimes removing any gynecologic organ like the uterus or the ovary, etc. Here's some other lesions. These are kind of white lesions. Again, we're usually able to kind of pick those up and take them out. And then if you do have a cyst on the ovary, That's an endometrioma. The fluid typically looks like this, kind of this chocolatey color, and this is pretty classic for endometriosis. And you can see this is an ovary here, this white thing, and down, I lost my pointer. Down here is the uterus, and you can see things starting to stick together, which is what happens when we have inflammation in endometriosis. This is a normal pelvis. This is a normal uterus. These white things are normal ovaries. No, everything's slipping and sliding. There's no implants. There's nothing stuck. And then this is an endometriosis uterus, belly, abdomen, where this ovary is stuck to this ovary. They both have cysts in them, and everything's kind of stuck. So that's kind of what we're looking for. And we try to put things back the way they should in endometriosis surgery. So there's endometriosis staging, and it depends on where the implants are, how many implants there are, how large they are, and are they on both sides of the pelvis, or are they bilateral or not? Something that's important to keep in mind is pain doesn't correlate with stage of disease. So I get a lot of people with a ton of pelvic pain. We go in, we find endometriosis, it's stage 1 or 2, and they feel like, again, not validated in their pain. They're like, why do I feel so much pain if it's only stage 1 or stage 2? And it's really important to note that the stages do not correlate with pain. And you can be stage 4 and have little pain. You can be stage 1 and have a lot of pain. I think what's important to note is, do you have it or not? And then we move on for treatment options. But staging is really just kind of a way for surgeons kind of talk to each other to like understand surgically how difficult or what techniques we would need. They did try to develop these stages to predict fertility and to predict pain, but they haven't really been shown to do a good job of that. So while I think, everyone wants to know about their body and they're curious about what stage they are, I wouldn't get too hung up on it from like a validation standpoint. The pain is definitely real, even at stage 1. This is, again, another staging and like a artistic diagram of where the endometriosis can be. Again, these are the ovaries. This is the uterus. This is the bladder up here. This is the colon. And these little implants are throughout the pelvis. And you can see adhesions forming these little cobwebby things. And then we can use this scoring system again, to get a stage. So what is the treatment? The treatment is based off of how endometriosis reacts. So while we don't really know how exactly it gets there, although we have some ideas, we do know that it likes estrogen, specifically the cycling of estrogen. So the implants act similar to the lining of your uterus. So after you have your period, all of a sudden your lining is thin and your body's getting ready to ovulate. During this time, days 6 through 14, your estrogen is going up, 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 up. Your ovaries are deciding who's going to ovulate. One of them ovulates. And at that point, your lining is pretty thick. And at that point, your estrogen starts to fall. Your progesterone takes over and kind of, what I say, like freezes everything, waits to see if you're pregnant. And then whenever it determines you're not pregnant, that progesterone falls and you have a menstrual cycle. In short, the reason I bring this up is because this cycling of estrogen is what is expanding this lining, growing this lining. And similarly, it's what's expanding implants and kind of allowing them to proliferate and grow. So a lot of the treatments are really aimed at estrogen to try to decrease estrogen overall, or to try to level off estrogen so you don't have this up and down, up and down. For these reasons, we get a lot of myths about endometriosis, like endometriosis is cured in menopause, or just have a baby, it's cured in pregnancy, or in breastfeeding, you don't have endometriosis. These are all low estrogen states: pregnancy, breastfeeding, menopause, and typically endometriosis does feel better during those states. But I like to kind of always keep in mind there is no cure for endometriosis. It doesn't go away. It just becomes usually a little less active in those states. And we kind of try to mimic some of those states with some of our medications we use to bring about a similar effect. So in short, suppression of endometriosis suppression of estrogen regresses endometriosis lesions. They can be better in menopause or pregnancy. And pain is most prevalent in women of reproductive age. So our treatment is anti-inflammatories. Again, that's like Motrin, ibuprofen. You can be on a combined hormonal contraceptive pill, and that's usually your typical birth control pill that has estrogen and progesterone. And I get a lot of like, you just told me how bad estrogen is. Why would you give me estrogen now? because the birth control pill gives a low steady state of estrogen, and then in that last week it drops off a little bit, whereas your body's doing this. So when we give you a pill with estrogen in it, it's typically less estrogen than your body is making, and in a different fashion. It's not really quite as cyclic with as many peaks and valleys. When that doesn't work, we typically move on to progesterone only medications. That can either be a pill, an IUD, a Nexplanon, or like an implant in the arm. It can be an injection. This is a picture of an IUD here. And then usually after we know you have endometriosis by surgery, there's also a couple other options available. And these are your anti-estrogen medications, I think of them. This is Orlissa or Lupron. These are good for pain. The downside is they have some menopausal side effects like hot flashes, mood swings, vaginal dryness. They can be kind of mitigated with giving back a little bit of hormone, and there are some nuances about them. But I would say these are typically reserved for someone who's already in care and has had surgery for endometriosis. And those are reversible. So when I say it gives you menopausal side effects, they are reversible. You can come off of them and become pregnant in the future. It doesn't put you into menopause permanently. So surgical treatment, this is where we kind of go in, we take out little lesions. That's called excision of endometriosis. Surgery usually gives about 2 to 6 years of pain relief on average from some recent studies. And there has been shown to be benefit to a hysterectomy with or without sparing the ovaries or leaving them. So in the olden days, again, going with like the get rid of estrogen theory, many women who had endometriosis, when they were done having children, would have a hysterectomy, and we would take their ovaries to totally get rid of estrogen. And now we've seen that women have benefit in pain, even if we just take the uterus, and we can leave them with their ovaries for more years so that they can have benefits such as heart health and bone health and things that the ovaries provide. And then they don't have to take like a hormone replacement. So again, these are more nuanced and definitely a conversation to have with your surgeon if you're heading down this route. But I think it's important to note that if your surgeon says we have to take the ovaries, you have endometriosis, that's kind of fallen out of favor in recent years. And I would continue to seek opinions until you feel totally comfortable with the plan, if that's something you don't want to do. Dr. Patnam spoke on this, but I get a lot of people who also have other conditions in addition to endometriosis, specifically high tone pelvic floor. And she had talked about how your body reacts to pain. You might have both going on, and you probably have to treat both. And this is kind of similar to hers, how I talk to my patients. If every single day you walk down the street and someone punched you in the stomach, you would start walking down the street with your abs like clenched because you would be prepared for this pain. Well, if every single day you have pelvic pain and your pelvis hurts, then your pelvic floor just stays in this kind of tense, clenched state as a reaction to what your body's going through. So not only do you have to treat the endometriosis, but you also have to treat the high tone pelvic floor, the pelvic floor muscle spasm. And she is the expert in that, but pelvic floor physical therapy, there's a lot of benefit to that. You can get trigger point injections and medications to help relax the vaginal floor. But sometimes I feel like when we say that, you have high tone pelvic floor, it doesn't mean that you don't have endometriosis. We just want to kind of do like a multifaceted, multi-targeted approach to really give you the best chance at improving your pain. We have pelvic floor physical therapists here. This is their number, the Pittsburgh region, the Erie region. They're wonderful. And if it's something you're interested in, your gynecologist or us can give you more information on it. But I think they're very beneficial. I would say, and Dr. Patton, if you disagree, but I usually tell my patients at least 6 visits before you see if you're getting relief or not. Because just
very much agree with that.
Yeah, just like if you're getting physical therapy for your shoulder or something, you have to kind of give it a chance. And sometimes you can have increased pain after the first visit just because like you're working out muscles that haven't been stretched or out of spasm for quite some time. So I've seen women have a lot of benefit from it, but you kind of have to give it a real try.
It's definitely something where I think it scares people the first time they try it because it can cause a lot of pain. But it's also, if anyone's ever gotten a deep tissue massage, when they kind of really dig into those deep muscles and it hurts, but then there's sort of that relax and that release. That's really what we're going for. So it's a commitment, but it's a commitment we think is really beneficial. And most of our patients who do stick with it, even if they don't have complete relief, will have some significant relief with it. And if you don't have complete relief, that's where I, again, come back in to help with other things that we could try to help with it.
There's a lot of talk about is there like, what other cures there besides hormonal suppression and surgery? There is some evidence for endometriosis diets, but it's not really as like special or fancy as some might think. It's just an anti-inflammatory diet. So it's very similar to like your Mediterranean diet or like your IBS diet. Basically, these are just foods that decrease inflammation, similar to your interstitial cystitis or chronic bladder pain diet, avoiding caffeine, sugar, alcohol, fried things, fatty meat, processed foods, just kind of decreasing the inflammation overall. So while there is no diet to like cure it, I think people do feel better with any sort of inflammatory condition when they kind of go towards these more anti-inflammatory foods like nuts and seeds, plant oils, fish, avocados, olive oil, peanut butter, whole grains. Endometriosis and fertility is a little tricky. ACOG is our kind of governing body for obstetrics and gynecology. And overall, they've looked at like all the evidence and all the research articles, and they do think that surgical management of endometriosis related infertility does improve pregnancy rates, but they don't know exactly how much or by what magnitude. So a couple caveats. I think, first off, 70% of women with endometriosis do become pregnant without need for ART or assisted reproductive technology or like IVF or some sort of medical intervention. So if you do have the diagnosis of endometriosis, it doesn't necessarily mean you're definitely going to be infertile. I see a lot of women worried about that. The odds are in your favor as far as that goes. Now, each one's different. So I think also surgical findings kind of help to predict this. So during surgery, we can see if the fallopian tubes are open. We can tell you, is everything adherent and stuck together and kind of distorted? Or is everything kind of in the right place and there's just some implants here and there? I think those can also help to predict if you're going to struggle with infertility or if you're not. So, overall surgery has been shown to help fertility, but I think it is really a case-by-case basis. And there are lots of different recommendations as to if you have a cyst, should it come out or should it stay? That depends on size of the cyst. It depends on kind of ovarian reserve or how your ovaries are doing, whether it's worth the risk of going for the cyst. In short, I kind of tell my patients, if you have endometriosis and you're looking to conceive, I would try to conceive. If it's not working, though, have a low threshold to seek help and seek care. And in a typical case, to diagnose infertility, people usually have to try for a year in order to become diagnosed with infertility. I think if you have endometriosis and you're coming up on the 6-month mark, I think it's okay to be proactive and knowing that you have that diagnosis, try to get involved in care a little earlier. So I think that's how just this statistic. And if you haven't had surgery before, but you probably have this, that's kind of how I would guide your efforts in kind of being proactive and seeking care, is just try. If it's not working, maybe reach out earlier to your physician about doing other things such as surgery, and maybe seeing an infertility specialist if needed. This is some of our main team that takes care of pelvic pain, but there are others. I'm in the top left. My partner, Dr. Rindos, is in the center. We're both minimally invasive gynecologists. So we deal with like the surgical and medical treatment of specifically really endometriosis, ovarian cysts. Dr. Patnam is a pelvic floor guru, and she helps us, again, with a lot of these same conditions that people have even with endometriosis. And she is a urogynecologist. And then we have Dr. Nosik and Dr. Hassinger, who are colorectal surgeons and also deal with pain. And so they would be your people for like sometimes IBS. And then if we do surgical management of endometriosis and we're worried about endometriosis on the bowel, we often do joint surgeries with them so that we can fully resect it at time of surgery. This is probably overkill, but this is just the diagram more similar to Dr. Patnam's, but on endometriosis and kind of patient information. And this can be Googled again under Nature Reviews and kind of give you more information. So I wanted to leave time for questions. But thank you for having us and letting us speak to you on these topics.
Yes, thank you.
Thank you so much. That was great. Apologies if you were trying to submit a Q&A. We had a couple of bugs, but I did have some questions submitted both in the Q&A and privately. So I'll start off. Someone said, thank you for bringing awareness to pelvic pain and endometriosis. Is there a way to be able to differ between nerve injury post-surgery, or if there is endometriosis specifically in the sciatic region?
That is a hard question. And I think the thing to kind of keep in mind with any of this is at the end of the day, it sometimes doesn't matter where it came from as much as the treatment for it ends up being fairly similar. And Rachel, do you want to speak more sort of like surgically with trying to find lesions in certain areas?
Sure. I mean, we're as pelvic surgeons, we're typically not in the sciatic region. If there is really a lesion on a nerve, sometimes it can be seen on MRI, and I would work with my neurosurge colleagues, and I have reached out to them sometimes about concern for lesions on nerves. But usually this would be something that's actually visualized on imaging that then they would target and go after. I will say, if like it's a new pain and you're trying to decide, is it endometriosis or like a sciatic nerve injury? Usually endometriosis would have started, in your earlier. So if all of a sudden you have just this one pain and it hasn't been painful periods throughout your life, you don't already have a previous diagnosis, I would be more inclined to think it's probably the sciatic nerve itself versus all of a sudden an endometriosis lesion implanting there. But if you are someone who, already has diagnosed endometriosis and is just worried, did it spread there? I think an MRI is your first step. Alternatively, we could try medications to suppress it and see if all of a sudden you get pain relief whenever you're on an endometriosis suppression medication. That would make me more skeptical. And then I would have to get help from my neurosurge colleagues for the specific region. I don't know if that answers the question, Dr. Patton, but.
No, I think that's pretty fair. I mean, I was going to say, I think a sciatic area would be kind of unusual for an endometriosis lesion, but.
Yeah.
All right, thank you. Okay, we're going to test my pronunciation here. I'm not clinical. How different is adenomyosis than endometriosis, and can you have both?
You can have both. I kind of think of them as cousins of each other. You don't have to have one to have the other, but endometriosis is whenever a tissue similar to the lining of the uterus grows outside the uterus. And adenomyosis is whenever the lining of the uterus like grows into the muscle of the uterus. I think of them as little like lakes or tributaries like going into the muscle. And textbook adenomyosis causes really heavy periods that also can be painful, but really heavy bleeding is like the hallmark. And it usually can happen a little bit later in life. Endometriosis is heavy, painful periods, but really painful is more the focus. And it usually starts earlier in life. So oftentimes I do find both. Adenomyosis sometimes on imaging can show like an enlarged uterus. Those are kind of like clues, but in short, you can have both. They're both tissue in the wrong spot. It just depends what spot, if it leaves the uterus or not, is how we essentially diagnose them.
Thank you. And while we're at it, do you want to flip to the next slide? Just in case anyone has to jump off a little bit early, we do have some resources available. So we have sleep and stress management as our next group chat coming up. And then we also will have birth control and menopause and migraines, which will be our summer session, which will be opening shortly at that QR link. If you want to inquire about pelvic floor therapy or find an appointment, and the middle section has different resources. And then on the right side is also links to our website for more information about the topics we discussed today. And also, if you have any feedback or additional questions, feel free to email us at that email below. All right, and I'll jump back into questions. Can an endometriosis cyst burst when it is on the ovary, and would it be painful?
An endometriosis cyst can burst when it's on the ovary, and it would be painful if it did. However, compared to other types of cysts, usually endometriosis cysts are pretty thick-walled and less likely to rupture than what we call like our functional cysts, or our cysts that are just kind of made with ovulation. So in short, it can, and it would be painful. Typically when people have, I hear of patients having a bunch of cysts, or like I get a cyst every 3 months and it bursts and it hurts and I go to the ER. Typically those aren't endometriosis cysts. Typically those are functional cysts or even hemorrhagic cysts, which is basically when you ovulate, almost like a little pimple or vesicle that forms, or like a little bruise. If you ovulate near a blood vessel, forms like a hemorrhagic cyst. So in short, yes, it can. It would be painful. Typically, when you have someone with a lot of cysts that keep bursting, going to the ER, typically it's not endometriosis. But those are just patterns and not firm rules.
In what stage of the menstrual cycle is endometriosis pain the most prevalent, and how common is it to experience worse pain when you're post-period?
So usually endometriosis pain is most common like in the day or two before you start your period, in the first couple of days of your period. However, I do have a lot of women who have a lot of pain post menses. And I think that can be attributed to, at that point, your inflammation and your what called inflammatory cytokines are so revved up from like this whole week of bleeding that like just in general, your pelvis is super inflamed at that point. So I have had people say that. And I think really any pain, a little bit before your menses, during your menses, or after your menses is really quite common for endometriosis.
What results can someone expect from endometriosis surgery? Can symptoms return or worsen over time?
I'm sorry. I was trying to follow on the chat. Can you
Oh,
repeat?
sorry. This is what I have sent privately.
Oh, okay.
What results can someone expect from endometriosis surgery? Can symptoms return or worsen over time?
Typically, symptoms do return. Studies have shown that on average, people get about 2 to 6 years of pain relief from excision of endometriosis, where you go in and just take out the lesions. So, but most women, there's about a 20 to 30, well, I guess most isn't the right word, but about 20 to 30% of women do go back for future excision surgeries. And again, on average, that's like 2 to 6 years in between.
Mm-hmm.
I would say, you know, if you had surgery and like 6 months later your pain is back and worse, it's probably not that it just regrew. It might be that just surgery wasn't the answer for you, or just wasn't as successful in you as in some other people. But I think if there's been a healthy interval, like, you know, you're not getting surgery every couple months, I think that is normal.
And can endometriosis be missed if lesions are clear?
It can. And especially in young women, you get what's called atypical lesions. They look like little vesicles, little pimples almost, or white lesions. It almost looks like scar tissue. So I do think it's important. I always take biopsies of something that looks somewhat abnormal in the pelvis whenever I'm there, even if I don't see those kind of classic brown lesions, just because I do think it's important to look at what we call atypical lesions. But it is possible it was missed. And if you're still having cyclic pain, and pain is kind of classic for endometriosis, it may be worth another laparoscopy if you think that might be an answer, and having a discussion with your physician.
You said you're following along in the Q&A.
I was trying, yeah.
Do you see the question, can vaginismus?
Oh, this might be a Dr. Platinum question.
Can vaginismus be related to vulvodynia or endometriosis? That's a really hard one. And vaginismus in general, just to kind of define it, is a feeling of just pain in the vagina with sort of muscle tension. It's an older term, and it kind of really connects back to that high tone pelvic floor dysfunction that Dr. Culliford described in the slide. I think that at the end of the day, vulvodynia is something that can definitely be associated with vaginismus. And then, you know, high tone pelvic floor dysfunction and vaginismus can definitely be a result of having endometriosis. I think sometimes that we don't always have the best explanation for a source of something. And in terms of whether or not endometriosis could be something that's going on there, I think the first thing to ask is truly, do you have cyclical pain? You know, that's kind of the first thing that Dr. Culliford pointed out here, and it's a really important aspect of this. There's a lot of patients who I think get to her who have pelvic pain that's kind of unexplained, that everyone says, oh, well, it must be endometriosis. We can't figure out something, but it doesn't have that sort of clear explanation. And then when they get to me, it ends up being just that they have high tone pelvic floor dysfunction that's led to other things down the road. And I'll be honest, in the land of pelvic pain, we don't have the answers to everything because it's just not well known. I think pelvic pain has become an issue that providers are paying a lot more attention to, and research is being more widely spent on, because we don't have all the answers at this point.
Can I answer one more question on there? So there was a question about, is endometriosis going to be characterized as an autoimmune disease? I thought it was a systemic inflammatory disease. And I just want to clarify, because I kind of spoke to both of those. So I want to kind of clarify. In short, right now we think it is an inflammatory disease, but a lot of autoimmune diseases, whether it's like pulmonary fibrosis or in short, an autoimmune disease is when your body attacks itself. So autoimmune diseases create inflammation. So we don't have it quite figured out, but we think there's an autoimmune link. And we do see other autoimmune disorders in women more commonly with endometriosis, but we haven't quite figured out the exact pathway. So we try to treat the inflammation that is a result of this sort of attacking of our own body. So I hope that kind of makes sense. So is it autoimmune or is it inflammatory? It's definitely inflammatory. It definitely creates inflammation. But why does it happen in women? We're kind of going down an autoimmune road and like why some women are affected by it. I hope that helps.
And then, is taking birth control and skipping having your period a treatment for endometriosis?
It is, yes. And the way that works is birth control, which is estrogen and progesterone, kind of gives a low, steady state, trying to prevent that growing and shredding and shrinking and bleeding of those implants. So it tries to prevent the proliferation of the implants. And then skipping having a period works in a couple ways. I mean, in one way, most of the time, periods are the most painful portion of someone's cycle if they have endometriosis. So you kind of are able to decrease the amount of monthly pain you have and decrease that inflammation that gets revved up during your menses. So birth control is a treatment because it helps the lesions. We think it helps the lesions not kind of grow and proliferate as much. And then it also helps when you skip periods, helps to decrease the weeks that you typically would have your most severe pain. So it's usually a first line method. If it's not working, then we usually move on to other things. One other myth that people get hung up on a lot of times is if you're skipping your period, is there just like blood building up inside of you? Is that healthy? And when you're on these medications, the lining of your uterus stays very thin. So I think of it like the lawn, the grass isn't growing. So it's not like, it doesn't need to be cut. So the blood is not building up inside you. The lining just stays thin and doesn't need to shed.
I use that same analogy all the time. It's a good one.
The lawn's good for ablations, a lot of things. Yeah.
It's a good explanation.
We just have a couple of minutes left. Are there different methods for removing lesions, and why would one be used over another? For example, does location of lesions matter, like rectum?
Sure. There are ways of removing them through excision, which means like surgically kind of picking them out and cutting them out. And then there's ways to help like desiccate or destroy the lesion through burning. So those are like ablation and excision. And those are both techniques to kind of treat endometriosis surgically. I would say a lot of people try to excise the lesions or surgically remove them. And if it's over the rectum, they would definitely surgically remove it because you can't really burn the rectum. That could cause an injury. So there are some surgical nuances, but if someone had lesions on the rectum, I would do it jointly with colorectal surgery, and we would try to excise them. That's probably, I hope that answers your question.
All right, and I think that's all the questions that we have today. All right, so thank you so much again, Dr. Collifer and Dr. Patnam, for sharing your expertise with us. Thank you everyone for joining, and we hope we'll see you at a future session. Have a great day.
Thank you guys.
Thank
Bye.
you. Have a good day.